Hello, everyone, and welcome to the second week, Tuesday of the second week of the breakout sessions of the virtual Iowa Governor's Conference on Public Health. As you know, we usually meet in person in April to share best practices and lessons learned from our own public health experts around the state. But just like everyone else, we're pivoting and adjusting to new Zoom realities due to the coronavirus. Last week we had nearly 500 people join us, and we're having a strong showing this week too. So we're so grateful that you're here to join us and continue our commitment to learning and sharing. My name is Lena Tucker-Reinders, and I am the Executive Director of Iowa Public Health Association. And like I said, I'm grateful that you're here to join us today. We have two presentations today, both of which are eligible for CEU credits for dietetics and for CHES. To receive those credits, you just need to put your name in the chat box and tell me which credit you'd like, and I will follow up with you directly at the end of the two-week session. You'll also need to complete an evaluation form, and that link is available on the IGCPH website, which you can find at iowapha.org. The Governor's Conference is put on every year by Iowa Public Health Association and Iowa Environmental Health Association. We are both member organizations, nonprofit organizations that rely on membership support and donations to carry on our important work. I encourage you to join IPHA and contribute to the work that we do to unite and strengthen the voice for public health in Iowa. I'd also like to thank our sponsors for the virtual Iowa Governor's Conference on Public Health. Their commitment to public health in Iowa is paramount, especially in these times. The sponsors of the virtual conference are Aetna, Amerigroup, Unity Point Health, and the College of Public Health. And we also have some virtual exhibitors, people whose tables you would have visited at the Governor's Conference had we met in person. I encourage you to visit their sites and support their missions as well. That's ACES 360, Champs Software, Des Moines University, Healthy Hometown by Wellmark, Iowa Corn Growers Association, IDPH, Bureau of Chronic Disease Prevention and Management, and the Midwestern Public Health Training Center. I thank them again for their support and encourage everybody to go visit their sites. Before I introduce today's speakers, just a reminder that everyone is on mute, and to ward off any Zoom bombers, we've made it so that the chat function, you're allowed to chat with me and the presenters. I will be watching the chat box, so go ahead. And if you have any questions, put them in there, and I will then relay the questions to the speakers at the end of their presentations. And with that, let me introduce today's first speakers. We have Tiffany Conroy and John Davis, and they will be sharing information about Iowa's violent death reporting system and its role in guiding prevention strategies and saving lives in Iowa. And so with that, I turn it over to you, Tiffany.
Great, thank you. I'll go ahead and get my screen shared. All right, Lena, can you see my screen?
Yes.
Okay, great. So good afternoon, everybody. As Lena said, my name is Tiffany Conroy, and I am going to be presenting on the Iowa Violent Death Reporting System with my colleague, John Davis. We are also joined by Lisa Roth, who won't be presenting on the actual slides, but is available to offer any responses to questions that might come up during the presentation. So I am the Injury Prevention Program Manager at the Iowa Department of Public Health, and my colleague John is a postdoctoral research scholar at the University of Iowa Injury Prevention Research Center. Today, the goals of our presentation, or the objectives of our presentation today, is I'll be walking us through at the beginning, giving an overview of the history of this system, as well as the purpose and the implementation of how Iowa implements our Iowa Violent Death Reporting System. Then John is going to take us through some slides around some data that we've done some analysis on related to top causes of violent death in Iowa, as well as some of the common contributing factors to the deaths that we're seeing in our state. And then I will wrap us up at the end with giving some information about how we've used the data to create different visuals, reports, and offer some opportunities or examples of how you all might be able to take the information that we have and be able to use that to apply that to different prevention and response strategies within your agencies. So what is the IAVDRS or VDRS? It's the Iowa project of the National Violent Death Reporting System, which is the only state-based reporting system that pulls together more than 600 unique data elements from multiple sources. We take that information and put it into a dynamic and usable anonymous database. The system collects data across all violent deaths, which includes homicides and suicides, and across all settings and all age groups. So as such, the system is far more comprehensive than what's available elsewhere, and the data can be used to develop and tailor violence prevention efforts. So one of the things that is unique about this system, as it's mentioned here, is that we're not looking only at a particular age range or only a particular type of death. If it's a violent death, which in the next slide I'll go through what qualifies as a violent death for this system, we're collecting the data on it. So the IAVDRS is a system that's funded by the CDC. We started receiving funding in 2014 when the Iowa first received funding, and started collecting data on deaths in calendar year 2015 deaths. The first year we were collecting data only on the 7 most populous counties because it was just a pilot year to get up and running, but then going into year 2, starting with calendar year 2016 deaths, we were statewide. And so as we go through the slides today, we'll be highlighting data particularly from 2016, 2017, and 2018. And we are currently in the process of starting our data collection on 2019. But although we started with 2015 data, since that was only 7 most populous counties, we'll be talking about the statewide data from those 3 years of 2016, 2017, and 2018. What we do for the system is collect data on all homicides, suicides, deaths that result from law enforcement intervention, deaths from unintentional firearm injury, deaths that are of undetermined intent, or deaths resulting from terrorism. And the points of data that we collect include the death certificate, which we're able to receive from the IDPH vital records. We also collect ME records, so that's the ME1 form, autopsy reports, toxicology reports, and then also law enforcement reports. And so that includes anything from a call log for a law enforcement agency up to the actual investigative reports of what they're allowed and able to share with us. So really what we're trying to do is collect data from multiple sources to bring together not only the who, when, where, and how, so that kind of more basic data, but then pull together some of those other pieces that can help us to better understand the why the death occurred in the first place. And so as I mentioned in the last slide, there's over 600 points of data that we can collect information on. That doesn't mean that we collect all of that on every death. We're able to put in information that's included in those reports that we get from those different law enforcement, ME, and coroners, and the death certificates. And really what we're collecting information on is that the demographic information, so age, ethnicity, race, all of that. We're also then collecting information about the location of injury, some characteristics on the victim. We're also looking at the relationship of the victim to suspect. If it was a homicide case, we look at information on the weapons used. We can collect information on toxicology coming from the ME or the coroner's office. We can collect information around, did the person have a mental health condition, or are they receiving treatment? Same with substance use disorders and treatment. We can look at factors related to intimate partner violence, as well as physical health conditions, and other things including issues with jobs or finances. And so again, the data points that we're getting, or the data that we're getting, is coming from law enforcement death certificates or coroner and medical reports, and we're collecting that data specific to the incident of death. And so the pieces of information that we get have to be included in that information that we would get from the law enforcement officers that investigated the agency, and the death certificates that are provided, or the coroner and medical. So there's a broad range of information that we can get. One of the other unique points of this system is that we are able to link together deaths that are connected to each other. So for example, if there's a multiple homicide situation, or there's a murder-suicide in which someone completes a homicide and then they themselves die by suicide, we are able to link together those incidents in our system to better understand some of those contributing factors that might be across the different incidents. So there might be multiple victims, but it was a single incident. And then how we implement the program here in Iowa is that the Department of Public Health receives the funding from CDC, and we are responsible for the overall project direction and oversight. So I serve as the project director within the Department of Public Health, and then we contract with the University of Iowa at the Injury Prevention Research Center. So that's where my colleague John Davis, who's going to present on our data next, is with, as well as Lisa Roth, who serves as the deputy director of the IPRC. She does the day-to-day kind of oversight for the University of Iowa team. And then we also have a full-time data abstractor who works with the IPRC, and she's the one who's really doing the outreach to law enforcement agencies and the coroner and medical examiners, and taking that data, abstracting it, and then putting it into the de-identified database through the CDC. We receive our data, as I mentioned, from death certificates, which we have a data sharing agreement in place to collect that information directly from the Vital Records office within the Bureau of Health Statistics at the Department of Public Health, where I'm at. We also then get the death records from the coroner or medical examiners. So we receive that either directly from the IOSME, which is the Iowa Office of State Medical Examiner. Then we also receive records directly from both Polk County and Johnson County, who are two larger counties where they will conduct their own death investigations and autopsies. So we have data sharing agreements with those three entities to receive those records from them. And then we also have a MOU in place with DCI, which is the Division of Criminal Investigation at the Department of Public Safety, the state agency. We have an agreement in place that their staff will put in the law enforcement investigation data for DCI investigated cases, which tend to be larger scale cases or more difficult to investigate cases. Smaller jurisdictions can call in the DCI to come in and do investigation on those agencies. So we work directly with them. For cases that were not investigated by DCI, we get that information directly from the law enforcement agencies. And then we also have an advisory committee. So that is meant a multidisciplinary team of both data providers, so law enforcement agencies are participating, coroners and medical examiners. We have vital records representation on that. And then we also have broader representation from agencies that might be interested in using the data for their own program and development or policies or prevention efforts, or also different agencies where they might represent a population that is at a higher rate of dying by suicide or experiencing homicide. So working with homeless services, veteran suicide prevention, Department of Education, so different agencies that they may not be a data provider for the system, but there's significant value in having them present to provide that feedback, guidance on data analysis, as well as them being able to see how they might be able to use the data that we have with the system in their own efforts. So with that, I'm going to turn it over to John, and he's going to show us some of the analysis that we've done thus far on 2016 through 18 data. John, I'm going to stop share.
All right, so I've shared my screen. Can everyone see that all right? Or Tiffany, since you're the only one to chat with me.
Yep,
right.
I can see you, John.
Great, thanks for all that. And so I'll talk a little bit about some of our results that we have from this data, from that big infrastructure going into collecting all of this. And like Tiffany mentioned, I'm with the University of Iowa Injury Prevention Research Center. I'm a postdoc with them, and I do data analysis for the IAVDRS system. So I'll be presenting some of the data that we've collected over 2016 to 2018. So if you talk to people who work outside this field and you ask them, well, what do you expect to make up the majority of our violent death reporting system? I think a common guess is homicide, thinking that this is where our burden of violent death lies, but it doesn't. The vast majority of the violent deaths in Iowa that occur are suicides. So that's where we have the most data and the most power to investigate what might be causing or leading to suicides or occurring around suicides. When you have something that's a little bit more rare, like homicides in Iowa, it's a little bit more difficult to piece apart what's causing those. But as the system matures, we're able to answer research questions or public health questions around that as well. So these are the numbers for 2016 through 2018. So it's 3 years of data. And like I said, the majority of what we're seeing is suicides. So using what we have in the system, we can look at how this differs across age groups. And it's apparent that suicide is it's a greater risk within those middle age groups of 25 to 44 and 45 to 64. Whereas homicides are more frequently occurring in a younger population. Some other differences we can piece out is differences across sex. And here you see 2 pie charts. The males are in blue, the females are orange here, and it's clear that males are at a higher risk for both dying from either of these outcomes here. Making up more than 50% in both cases. And then we also see some racial differences with African Americans relative to the population of Iowa being a little bit lower for the proportion of suicides that occur, and higher for the proportion of homicides that occur. And this is for victims or decedents of either of these types of death. So we want to use the system to understand what is happening around suicides and homicides. And like I said, because suicides, it's more common, we can we have a little bit more power to investigate what's going on around them, so we can give better descriptions of what may be leading to suicides in Iowa. And this is a snapshot from 2016 and 2017. You'll also find similar stuff to this in our yearly suicide reports, but I've organized this in a way to where at the left of the table, you see some circumstances related to mental health that we may identify occurring around a suicide. In the middle, there's some different circumstances regarding relationships or things like school or argument problems, all the way down to alcohol, substance abuse, and then some job and legal problems at the right of the table. And none of these are mutually exclusive. Someone can both have a mental health problem recorded around their suicide, as well as substance abuse recorded around their suicide. And that's very common to see multiple circumstances. So this is not a comprehensive look at what's causing someone to die from suicide, but more of what are we commonly seeing occurring around suicides. And where we get this information from is those ME, the medical examiner reports, and the law enforcement reports. Those get abstracted, and we're able to identify different types of circumstances that occur. And the picture from this here is that we see a lot of circumstances related to mental health being more common, and towards the right we have the financial and job and criminal legal problems that are more rare, but it is also something that we understand that in 2016 to 2017, these type of problems were less frequent than they may be in the coming months. So looking at job and financial problems, we are trying to more actively survey those things as potential contributions to suicide. So finally, I'm going to talk to you a little bit about what we see across rurality. We looked at the resident rurality by census block and categorized people using the rural-urban commuting codes, the RUCA codes, and from urban, large rural, small rural, and isolated to see if we saw any differences based on where people lived. And when you compare groups like this, you want to make sure that you're controlling for other things that might explain higher or lower rates of suicide. So in this, we standardize for age, sex, and year. And when you do a standardization, the way we look at this is what's called the standardized mortality rate. And you look at typical rates across ages and sex and year, and basically look at the population for any of these groups, and you get a expected number of deaths. And if what you actually observe is higher than that expected number, you can say that that area has a higher mortality compared to other areas. And we get measurements known as the standardized mortality rate. And to the far right of the table, you get a 95% confidence interval, and that gives you an idea of some uncertainty around those measures. So the group that sticks out the most to us is the large rural group that has a standardized mortality ratio of 1.23. So we interpret that as people living in large rural areas have about a 23% higher risk of suicide than other areas across Iowa. So that is an area that we're interested in doing more to outreach and more work in preventing those type of suicides. To drill in a little bit more, we can look at the individual age and sexes in the large rural areas and compare them to similar age and sexes in other areas. And again, those bars are a measure of uncertainty. So where suicide is rare, like in the over 64 females, you get a lot of uncertainty. Where it becomes more common, you get tighter or smaller confidence intervals. So you're a little bit more certain about what you're finding. And what we see is driving that higher suicide rate in large rural areas is it's among the 25 to 44-year-old females and the 25 to 44-year-old males. So again, these are groups that we're interested in doing more preventative work for. But I will switch back over to Tiffany, where she can talk about some of the outreach we've already done.
Thanks, John. Can you hear and see now? Okay, great. So for the last portion of it, we just want to give you all some examples of ways that we've applied the information for different sectors or different ways that we've visualized the data and what we're seeing. So one of the things that we did in the last year is broke down the counts and rates by lean region. Lean region is the law enforcement investigative network region. The red numbers that you'll see on this screen correspond to the number of each of the 6 regions by law enforcement designation. We worked with the coordinators of each of those regions to go out and provide an overview of the system, as well as provide them their region-specific data, drill down as far as we could. So what this looks like here is just, this is a visualization that we offered to each of the regions, and then did a little bit deeper analysis for each of the specific regions on the law enforcement agencies within that regions in terms of the response rates. So of those deaths that occurred in their region that we requested records on, what percentage of those cases did we get the records back? What was the timeliness in terms of the turnaround from date of request to the date that we received the records? And so those are different points of quality improvement that the CDC monitors us as a program on. So this year for 2018 data, we actually received for law enforcement records overall statewide about 82% of cases we received records on, which is the best that we've done. So we're very excited about that. But this is an example of how we were able to say, and this is just for 2016 and 2017 data, because at the time we did this analysis, we didn't have enough of 2018 data in the system to provide that. So this would look different when we pull in the year 3 data, but we just wanted to offer this as an example of something that we can do. And again, this is by law enforcement region, but we are able to tell them what's the overall count of deaths for homicides and suicides, that's for both of these, for both of those within each region, and then be able to break it down by rate per 100,000 per county. Depending on the color of green, that shows the rate, with the darker green having a higher rate. And then for the white counties, the data was suppressed based on our data suppression policies within the health department. If it means that, we weren't able to provide data because there wasn't enough deaths within that county. So this is one example of a way that we are able to give some visualization in terms of a statewide, but then also breaking it down a little bit more granular into regions, and then even more down into the counties where we could. Another thing that we do with the data is we do produce an annual suicide report. So we do have one for 2016 or 2015, 2016, and 2017. We will be shortly starting the 2017 or 2018 data. As a system, we have 15 months after the end of a calendar year to finalize all of our collection of the data for that year. So that means right now, we have just finished up the 2018 data collection. And so then we can then start producing the annual suicide report shortly thereafter once the data collection has ended. So for the 2015 report, we have it just for the 7 most populous counties, and then 2016 and 2017 reports include data from all 99 counties. These suicide reports are specific to Iowa residents. And so although we would collect data on a death where the injury occurred in our state, but they weren't a resident of our state, for example, in Council Bluffs, and they lived in Omaha, or vice versa with the Quad Cities, when we break it down by these reports, we're looking just at deaths that occurred in Iowa where the person was a resident of Iowa. So just giving that kind of distinction in terms of who's included in these. And what we like to do is just kind of break it down in terms of what we're seeing by the majority of deaths, in terms of what type of death they are, looking at it by rates compared to the national rates, by sex, by method of suicide. And then we also can pull out information in terms of what are we seeing from some of those contributing factors that are showing up in the deaths by suicide in our state. And then what we've also done with that is then created some infographics, and we'll be working on these again with the 2018 data, and we always try and have stuff out now by September for Suicide Prevention and Awareness Month. And so we're going to be creating more infographics and things like this that we hope to be able to provide to folks to be able to use for your own social media or different marketing, whether it's for Suicide Prevention and Awareness Month, or if we have enough data that we can pull out for Domestic Violence Awareness Month in October, things like that. So these are the types of things that we'll be pulling out and creating visuals of. And this is one we just wanted to show specifically. When we looked at contributing factors for deaths by suicide, a physical health condition increased with age, which is probably not surprising that as somebody gets older, the likelihood of them having a physical health condition that contributed to them dying by suicide increases, but it's a pretty drastic percentage increase. If you look at this based on 2017 data, older adults, so in that oldest adult range, 68% of the deaths by suicides, there was some note of a physical health condition being a contributing factor to them dying by suicide. So that's just noteworthy in general, but this is just a representation of a type of visual that we've created with the data. And then to wrap up before we answer questions, we just wanted to offer some ways in which you might be interested in using the data. And so, if you want to use the information from our suicide reports, or different pieces like that in a needs assessment, that's a possibility. If you're, looking to write a grant application and to specifically target a particular population or focus on a particular geographic region, can you use this data to help guide that information in terms of the prevention and response efforts that you're doing? You also can reach out to us and provide suggestions or make requests for data analysis. There are ways that you could potentially incorporate the information into your own presentations and trainings. For example, Dennis Klein, who is a state medical examiner, has expressed interest in using it when he goes the information and going out and talking to county medical or county coroners. So ways within your own networks that you can provide the information. And then also, as you see this data based on, what sector you work in, if you are working in, older adult care or elder services, and you see that, older adults and elders in Iowa are at a higher risk of dying by suicide, does that help you identify that maybe working in suicide prevention services or partnering with somebody that's working in that agency might be a good partner to start doing outreach or collaboration with? So we will open it up for questions, Lena, whenever you're ready. We want to put this information up for more information of how you can contact us. And if you do have any questions about after today about the data or requests for any information, please send that on to me, and we'll of course take it through the appropriate channels for providing whatever information we're able to share back out to you all.
Thanks so much, Tiffany and John. This has been very interesting. I especially appreciate that you're making very user-friendly infographics and information for us to share, and we can all help with this important work. We do have several questions that have come in. A couple of them are just clarifying questions, so I'll go ahead and ask those first, and then some more discussion ones. The first one is, what is intent disclosed versus other circumstances? And I think this was directed at John.
Intent disclose. Oh, I see. Yes. So intent disclosed means that there was something in the record that identified that they had some intention of committing suicide. So that would be the intent disclosed. The other circumstances could make up a variety of things. So that's a little bit more wide.
Okay.
And
oh, go ahead.
Yeah, I was just going to add a little bit more on the intent disclosed. One of the things that we've done, I think it was in the 2016 suicide report, is we broke down the intent to disclose by age range and looking at those younger people, so youth and young adults, and their rates of disclosing, and looking at that in terms of like disclosing on different social media and things like that, and then breaking it down. When we get into the older ranges, what we saw based on that data is that older adults were less likely to tell anyone or make any public declaration that they had any intent to die by suicide. So that's one thing that we broke down previously, but we're interested in looking at further as we have more years of data to do some more analysis on that.
Sure. So the next question, and again, a clarifying question, is what urban-rural classification system are you using?
So it's the rural-urban commuting area codes. Okay. So that gives not just a picture of population in an area, but also how near it is to urban centers. So it's a little bit, it can be a better metric for some health outcomes because an area without a large population outside of a place like Des Moines is going to have different health characteristics than a place that has low population and everyone around them also has a low population.
Okay, and who collects that data originally?
The location information or the
commuting data?
Oh, the commuting data. So that's published by the Rural Health Research Center. It's I believe it's University of Washington that collects that data.
Okay, good to know. I think that's useful data that for lots of programs probably. So the next question is how is this or do you train and share this information with mental health providers? And how do you incorporate mental health providers into the prevention efforts?
Yeah, that's a great question. So that is the direction that we're heading next. So although we received funding back in 2014, we are just now at the point that we have multi-year data that we're able to do more analysis on and giving more meaningful data out to kind of the general public or different stakeholders. And so we historically have, just been collecting data from our data providers and not able to really produce anything back out other than the suicide reports. So we have been working both with, we work with the Department of Ed in terms of the youth mental health first aid, their work that they do through the department there, and having their representation on the advisory committee, and then providing that information to them that they can put out through their networks. We also are partnering with Zero Suicide Program, which is within the health department as well, and they're focusing on providing information to the integrated provider network, which is substance use and behavioral health programs, and so getting that information out and then through the Suicide Prevention Advisory Committee. But we really welcome requests or suggestions or ideas. If you have a meeting of providers that you would like us to come out and just give a 20-minute talk on, or a 2-hour presentation, or I know things are kind of up in the air with COVID stuff right now, but we are really at a point now that we can start doing more outreach and more data provision and more guidance and training. So we welcome any requests or suggestions. But right now it's been mostly just trying to get the data analysis we have back out through some of those systems to get it out to their networks.
And what kind of partnerships do you have, or are you hoping to develop on the homicide side of violent death?
Great question. So one of the most recent partners that we are working with is the Iowa Coalition for Collective Change. They're a statewide organization that provides membership for homicide programs and other violent crime victim service programs around the state, and culturally specific programs as well. So we've just started kind of building a relationship with them specific to the violent death reporting system. And then it's been primarily law enforcement. So, we work really closely with DCI. Their leadership there have been really supportive of the team, and they're the ones, DCI is what helped us get connected with those law enforcement regions and to be able to get out on the ground and providing feedback to law enforcement, who are the ones that are potentially investigating the scene of the crime and ongoing after that, and then just local law enforcement jurisdictions as well. So as John mentioned, our homicide data is more limited, just because of the number of deaths in our state. And then one of the limitations of the system is that we're collecting data on the decedent, the person who died. And so yes, there might be some information on the person who completed the homicide based on their relationship to the person who died, but we're really not getting a ton of information specific to the person who completed the homicide. And so that's one area that we're always looking to figure out how we might be able to better support. When we're really talking about upstream prevention, like preventing the death from happening, the more we can understand about how we can work with or support the people who are at risk of completing homicide is beneficial. And so that's an area we're looking to explore as well.
Right. I can see programs that are working on really upstream health equity, social determinants type of work, really making use of this data as well.
Absolutely.
Here's a COVID related question. How quickly will you be able to assess and see if there's been an increase in suicide or homicide that could be attributable to COVID, given the mental health implications and of social distancing and economic impacts and all that?
I'll give a brief answer and then I'll turn it over to John to give the more technical answer. It is a big part of our conversations right now. So as I mentioned, we have 15 months after the end of a calendar year to finalize our data collection, but that's everything. That's the death certificates, the law enforcement records, and the ME reports. But we pretty quickly get death certificate data. We get that information twice a month, and that is typically with of deaths that occurred within the last 1 to 2 months is typically the time frame. And so we're trying to figure out right now, because the system is not naturally set up to be a more quick time surveillance system, we're trying to work with our Vital Records office, our Zero Suicide program and data manager for suicide prevention to figure out how that might work. So we haven't quite figured it out, but John, if you want to add anything in there in terms of how you kind of envision that might look, but it's on our radar right now for sure.
Yeah, you covered a lot of it. There is that 1 to 2 month delay, and then there's that much longer delay to understand the circumstances around a suicide. So it'll be difficult if we see to find circumstances changing right away. But what we hope to do is do more proactive surveillance among different across demographics and location. So that way, if we do see something that is higher than what's expected, we can more effectively address that. But it is something where all the complete information needs to be abstracted from records, and that takes a while. But what we can do is more actively look for the numbers like in counties or across age groups, so that way we can more effectively respond to that if there is an increase.
Okay, great. Well, let's hope that there's not, but and I know that many of us are sharing all kinds of information about mental health resources during this time. So thank you both for this presentation, for sharing with us today, for kind of being flexible with us on the presentation format and everything. So it's such important information to share, and I'm glad that we've been able to get this out to our colleagues.
Yeah, thank you for the opportunity, and we just welcome any questions after this from anyone, so please don't hesitate to reach out.
And we will be posting the video and the presentation to the IPHA YouTube channel in the next couple days. So if you have questions, that's where you can go to find out more information if you haven't been able to copy down Tiffany or John's contact information here. So now we're going to transition to our next presenter and presentation. And next up we have Sandra Burke with ISU, Iowa State University. And Sandra's going to discuss with us the U.S. Census and how that impacts local public health. So with that, I will turn it over to Sandra.
Okay, oops, wait, sorry. Okay, let's get this going. I'm going to share I think I'm sharing my screen.
Yep, we see it.
Okay. There we go. Okay. All right.
There it is. Perfect.
Okay. Thank you for the Governor's Conference into Public Health for making this a virtual conference. At least we can share some of our things. I'm Sandy Burke, and I'm with Iowa State University, and I'm part of Extension to Communities, and we have a data team. And our data team does a whole variety of things for data, and one of them is health data. But we wanted to talk here, since I'm a demographer, sociologist, I've worked a lot with census data, and we wanted to talk today here about Decennial Census 2020. It is happening now, and it is still happening, which is, we appreciate the opportunity to talk about that, and then what it means for community health, because it does impact our community health in a variety of ways. So first off, the census, the decennial census, is done every 10 years, and the U.S. Census Bureau counts every person and every housing unit in the United States. It's done in the years ending in 0, and it is a self-report survey that's sent to every household. And what many people may not know is that it's mandated in the Constitution to apportion Congress, and we'll come back here to a couple of those points. But what it means for community health, well, it means lots of things, and you'll see how I've written that there, and we'll get to that here. So first of all, you all would be aware of China HIP, all right? Periodically, you have to do an assessment and planning. Well, when you do assessment and planning, you need to know your number of people, the age, sex, race, Hispanic origin, household and family structure, housing, renters, owners, and a whole variety of social and economic circumstances of people, because this affects their health, There affects their access to health, and we know that these are social determinants of health. This is one of the census is one place, and an important place where we get this kind of information. Now, here is my lots of things for health. It means money. And what many people may not know is that many federal funds are distributed in whole or in part based on data derived from the decennial census. Well, who gets money from this? Well, hospitals, healthcare, Medicare, Medicaid, fire and police, schools, education, daycare, roads, public transportation, housing assistance, all things that are important for how our community functions and our community health. So there has been at George Washington University's Institute of Public Policy in Washington, D.C., a program that they've called Counting for Dollars. And they started a little over a year ago looking at the federal funding aspects of the census using federal fiscal year 2017. And remember, now we're into 2020, so this is actually a little bit back, and there's always data delay. They were looking at 316 federal spending programs that relied on census-derived data to distribute funds. Now, notice the date here is 2010, all right? And they were looking at this to look to see what a state or an area's receipt of the fair share depended on their receipt of these funds depends on the accuracy of, at that point, the 2010 census, okay? So what did they find? Well, for Iowa, based on programs that have largely on census-derived data, $13.71 billion in federal fiscal year 2017 for Iowa. Well, now we would think that would be even higher, given that the federal budgets should be somewhat higher than they were. We're in fiscal year 2020. So this is a significant amount for Iowa, and these are based on census-derived data. So what we have here is if we have an undercount, we're going to miss out on federal funding. So we'll miss out on something for which we are eligible, but every year, the undercount keeps on undercounting, sort of. So that number that goes into the formulas for these programs does not change, except for every 10 years after they have all the census counts. So if you miss out on something in the first year, you're still going to miss out on that on the second year and the third year, every year for us now between 2020 and 2030 for each person missed. So George Washington University suggested some amounts that we might miss out on. And so what we did is looking at if we have 0.1% undercount, that could almost come up to $90 million over that 10-year period of 2020 to 2030. If we had 1/4% undercount, we could be in the range of $224 million. If we had a complete 1% undercount, we could be pushing $900 million that we would not get, that we'd be actually able to get if we had had an accurate count. Before we had the coronavirus, some states were worried that they could have a 2% to 3% undercount. Now, typically Iowa is pretty good at responding to the census, but some states were very worried, and we'll talk about where they're at right now with this. So coming back to our list of what the census is about, I want to speak a little bit about the self-report survey and the fact that it's mandated in the Constitution to apportion Congress. Well, what do we mean by apportioning Congress? Well, it really simply means figuring out how many representatives each state has in the House of Representatives. So each state, by the Constitution, has 2 senators, all right? There's no question, everybody has 2. But in the House, the number that each state has is determined by our population. So overall, the US House has 435 seats. Well, we have 50 states, so you subtract 50 off the top of that, and that means that the 385 seats are distributed to the states based on population and only on population. So it's really important that we get a good count so we get our fair share representation in Congress, in the House. So currently Iowa has 4 seats, and based on our population estimates, I don't think we're in danger really of losing one of those seats, but I can remember back when Iowa used to have 6 seats. And it's not that Iowa over these last several decades hasn't grown. We have grown, but we've not grown as fast as many other states. Now we still have a handful of states that just have 1 seat. And a couple of them are nearby us, North and South Dakota, a couple over in the east, and a couple out in the west, because their populations are quite small compared to the rest in many other states. California has the biggest population. It has 53 seats. Texas has 36. Florida and New York each have 27. It's pretty well thought that Texas will gain. Florida will gain. California and New York may just hold the same numbers that they have. And Illinois, right next door to us, is likely, they have been estimated as losing population, and it is likely that they will lose a seat. So this does have political consequences for us. So now this self-report survey part. Well, I think by now we would have all, I hope everybody has gotten their letter, and I hope you've all responded. Okay. April 1st is always designated as Census Day, and this is just used as a standard date for which people should answer the questions on the census. This is what your letter would have looked like. And here in Iowa, we would have almost all gotten that as a letter in the mail. There would be some places where a questionnaire was hand-delivered to the household, but relatively few areas here for Iowa. This started a month ago, and so we should have all had this. If you didn't respond within a week to 10 days, you should have now already had a follow-up saying, please respond, all right? And the front of the letter says, yes, it's your response is required by law, and yes, it is required by law. There are federal laws that say every household must respond to the census. It's considered that important. Okay, so now this is what the letter inside would have looked like. You would have had a password, an ID password. Now, a new thing, the census, which was concerning to start, but now with the coronavirus, it may actually help us. This was the first time ever that one could have responded to the census online, okay? Previously, we would have all responded by paper questionnaires or phone in the recent past. Way back, probably 1940 and earlier, it would have been a census taker. And unfortunately, I think probably about 1950 was they started doing it by mail, but I'm a little unsure of that. But so you can respond multiple ways. So you need that census ID if you're going to respond online. So here's what happens. I, being a census aficionado, I copied out what happens when I did my online response. Okay, so this is what first comes up. You put in that ID, and then it asks you, are you completing the questionnaire for the address below? And for me, the address was correct. I've blocked it out, but that was my address was showing, and you click yes, and then you're going on. So then you first have household questions, and they will here ask you how many people are in your household as of April 1st. It will ask you the names of those people. It will ask for the phone number of one person, and ask, do you own it, your house, or you're renting it? Okay, so once you do the household questions, then you go on to people questions. And so here they will give you a list of all the names you entered in the household part. So there's me, and there's my husband, okay? So then you start clicking on the box to answer your household question. So what is Sandra C. Burke's sex? Okay, I claim female. So there we are for that. And you go on with the whole series. It was very easy to do. Very easy. Even when I started capturing and doing every question, because like I said, I'm a census aficionado. Okay, so they want to know for each person that you've listed, age, sex, age, race, Hispanic or Latino origin, and for anyone except that first person, how is that person related to the householder? So we go on then, and I've just put in here, if you have not yet responded, there is a web address to be able to do that. You can respond by phone with this phone number, 844-330-2020. You can respond by mail, and by now, if you had not responded, I believe you would have gotten not only your follow-up letter, but you should have also, I think by now, gotten a paper questionnaire in the mail as well. So follow it up, okay? The paper questionnaire looks like this. And here you see we have all the questions for person 1. And here you have questions for person 2. And the only difference is that the relationship questions are there for person 2. So now we want to talk about what is not asked on the census. There were some controversies. The census asked about citizenship or immigration. Research prior, there was an effort to put a citizenship question on the census. Research showed that that would decrease the response rate. And many folks were very, very concerned about this. And so there is not a census citizenship question or immigration status. All found scams here in Iowa, even not just other places, but here in Iowa. So the census does not ask for social security numbers, bank or credit cards, money or donations, or it does not ask anything about political questions, behalf of a political party, or anything. And some of those scams were asking for money. Some of those scams, unfortunately to say, asked political questions. So people, and those were mostly, I don't know if some have come out recently, but those were mostly in like early March, the 2 or 3 weeks before the actual census questionnaires were due to come out. Despicable scams. So anyway, and I want to mention here just a little bit about how questions are asked about race and Hispanic origin. Because we know that we need to, and we frequently want with health or any other kind of data, to know something about how our various trends and socioeconomic things are happening for different groups. In this census, and typically in the concept used by the Census Bureau, they do not consider Hispanic origin race. They view it as an ethnicity. And on the set of questions, they first ask the questions about Hispanic origin. So you click box no, you're not of Hispanic origin, or yes. And if you have a heritage you want to list, that you can click those, or you can list one down here, or just click yes and don't list any heritage at all. So this is a question strictly about Hispanic origin. It is not race. Well, so what does the Bureau view for race? Well, first of all, they view it as a social category or construct. It is a self-identified question. You self-identify who you are in terms of your identity and your race. They do say that it includes concepts of geographical heritage, national and cultural origins, as well as physical characteristics, but it is not an inherent biological quality. Strictly a social category or construct, and it is a still very important component of social identity and social reality. So that is what we are really measuring there, is social identity. And here's what happens here now. So here are the questions on the categories on race, and you are asked to choose one or more boxes. Well, previous to Census 2000, if a person would check more than one box, you would be automatically recategorized as race. And those multiple origins that you had chosen, or multiple race categories or identities, would not be tabulated. It would just come out as other. You would not see data tabulated by how many multiple origins people chose. That changed in Census 2000. And so now you will see tables that will give some of these details. And so this year also, for white and black, they're asking, can you print a heritage? And I will say, if you haven't done this and you want to just leave that blank on the online questionnaire, click white on the online, leave it blank if that's what you want to do. And then when you click next, it will tell you to fill that in, but just click next again and it'll go on, okay? So anyway, so now if you choose more than one, they actually tabulate those data. And you can find detailed tables. This is not one of the more detailed tables, but you can find detailed tables that will tell you how many people chose, for example, white or black, or how many people chose white and Native American combined, and how many people, in fact, maybe chose all of them. And in Iowa, we have 3 or 4 people each time who have chosen all of them. All right. So that's, now you can find those data table. But this typically shows how you find data now table. You will start out with showing the numbers or proportions who chose only the one race. And here in Iowa, 98% of us just choose one. And that is pretty typical. Most people nationwide only choose one of these kind of racial identities. So we are largely white still. Black is about, in the statewide, the 2010 census, 2.9%. We estimate now up about to 4%. Asian Pacific Islanders, American Indians, Hawaiian Pacific Islanders. Those are our smallest single tabulated race group currently. And then you see down here, it says 2 or more races. So you'll find that typically in a table there. And what we find then is a separate line or a separate column or something for Hispanic origin. And for Iowa and the nation as a whole, that is our largest minority group or persons of color, but it is not considered a race group. Then I want to come back up here and show you this category, white alone, not Hispanic. And what does that mean? And you frequently find that on the tables as well. That means that persons who chose only the white category and who also were not Hispanic. And so this tabulation, this amount here, for Iowa estimated now at about 85%, shows what we would call our majority-ish population, white Anglo, all right? If you subtract that number from 100, it gives you an easy way to figure out what could be our proportion, persons of color or minorities. It's an easy way without adding up all the other single race groups or so on. So that's just a little quick way to calculate what our percentage. And we are much less persons of color proportions than most states and many other states, nation, and certainly the nation as a whole. All right, so getting back to the census itself, your information is kept confidential, and it is to be used only for statistical purposes, aggregated with other households in terms of publishing the data. You will find data by communities, towns, counties, block groups, and so on, but you wouldn't, and they are, it's against the law for them to release anything that could identify a person or a household. Now we come here at this point in the census process, given that we are a month past when the census forms first went out, and we should now be responding, many people would now have had the paper questionnaire. At this point, somewhere in early May, they would have started sending out census takers to neighborhoods and to houses that had not responded. So we would then, if should there be someone in your neighborhood that is a census taker, they should have ID. They should have a Department of Commerce watermark on that ID, a photo, and all these sorts of things. However, because of coronavirus, this process is being delayed. And where it was supposed to start in May, they now are saying it won't start until after June 1st. And so what also is happening, normally the Census Bureau would have to deliver the first state counts to the president by December 31st. Well, they now, and there's a law that says that they have to do it by December 31st. And then there's some more laws saying they have to deliver the local counts for apportionment of the state legislative bureau districts by about March 31st. So that may get delayed because they are now delaying this whole census process, the follow-up process, etc., because of coronavirus. And they have made a request to delay those dates of when they deliver the actual counts, both to the president and to the states. They have to change laws to do that. So we don't know at this point. And I also want to mention that there are certain communities and groups that are considered sort of harder to count. So if you have not yet, I have one more slide here. If you have not yet responded, please do so this afternoon, okay? If you know of friends and colleagues, family who have not responded, have them respond. And it's easy to do this online. And what we did is we put on our website, which will come up here in a minute, some handouts. You could still use these. We were going to ask everybody to put these in your office to distribute them at meetings. Well, that can't happen now, but we still have the things on our website that gives details about the safety and how to respond to the census. Here's one that's has basics, but it's a little shorter. Here's one that's in Spanish. Okay, so you can find all those on our web address, which we'll show here at the end. We do know here now to talk about, there are some areas and groups that are considered harder to count. These are groups and areas that don't respond as readily to the census. They tend to be groups that are geographically, linguistically, or culturally isolated. Renters don't respond as well as owners. People with lower education, income, employment, non-traditional living arrangements, and this does include persons of color, racial, ethnic minorities, and children under 5. Now, those kids are just not responding to the census. Well, it's actually not the kids, obviously. It is their parents forget to count them, to include them in the survey. So don't forget to include your kids and your babies, okay? So now that we are a month past when the first questionnaires came out, the Bureau has a map that and a list of how we've responded. These are from yesterday. About half of the households have self-responded, and the Bureau wants to encourage everyone to possibly self-respond because that's the least expensive, easiest way, rather than having census takers coming around. We are now at about, as of yesterday, 57% of Iowans. The 2 counties here showing in the dark blue have the highest response rate. The counties in the low yellow have somewhat lower. Here's our 2 highest counties, Sioux and Bremer, okay? And I put in here our lowest, and you can do this by town as well. Let's cut Dickinson County some slack here on this, because Dickinson is up there at Spirit Lake and Lake Okoboji. And think about the fact that those housing units up there many of them will be vacation homes. And the census does want people to respond to where they actually live the bulk of the time. So Dickinson County, it's not at all a surprise that there would be delays, because those housing units will eventually get counted as vacation homes. Okay, so now here are our indicators website where we have our materials. And now what I'm going to do is, let's see here. I stopped the share because I want to try here to go to our live website. Okay, sorry, it'll take a moment here. And let's go here to our indicators website. Yes, and I've asked my colleagues to not mess with the site while I'm doing this. Okay, so when you get to indicators.extension.iastate.edu, here's what comes up. And I'm going to roll down first here to showing.
Andrea, sorry to interrupt, but we're not seeing it.
Oh, okay, sorry. Let's see here, Zoom. Oh, I need to share the screen again. Okay, how about this? And this, share. Now can you see it?
Yep, now it's there.
Okay, good. Sorry. Sorry. Okay, so let me roll this back up to the top. This is what you first come to, indicators.extension.iastate.edu. And we're going to scroll down right here to show you quick where our census stuff is. And here is the stuff that I mentioned, the handouts. These are links to Census Bureau stuff, to other organizations that have really good, useful census things, etc. Okay, so that's where you find those things, those handouts. Next, I want to talk about some data sources are things called data for decision makers. And we have city reports, legislative districts, 4-H reports, etc., that we think are quite useful. And here I'm going to show counties. And we have here 3 different kinds of county-based. County profile is a basic demographic. We update these annually, at least, as new data come out, particularly data from the Census, American Community Survey, and so on. So there's the county, but what I want to highlight here is the health profile. And we're going to go to Blackhawk County, and we're going to download this. A year ago, this got a grant to do, I do data literacy training, and I had a grant specifically to talk about health data literacy. And I managed to do, between this time and into the summer, 8 to 10 presentations, and I managed to have persons from, I think, 25 counties, public health people from about 25 counties at these various workshops we did around the state on the health data literacy. So this is what we have. These are brand new, updated as of yesterday. And we have here, we pull in data that come on the Robert Wood Johnson health factors, outcomes and factors ratings. But the Robert Wood Johnson data, not only the factors in the rankings, but they provide annually a really rich source of data you can just download, and things that are harder to find for county level data are right there for you. And so here we have diabetes and obesity. These items here at the lower left come from Burke, and they model those data down to the county level annually. So that's something that it's hard to find other places. We have births and deaths, cancer, hospitalizations for heart attack, food stamps, providers, doctors, dentists, mental health. So here is a way to see now that we're concerned about particularly the mental health aspects of coronavirus. The numbers of providers, and they do county per population, per provider. We have food stamps, and we expect that to go up because of the economy issues. We have disability, and here we have also that could be really helpful now with the coronavirus, hospitals and hospital beds, but we now have had some very unhappy incidents of coronavirus in long-term care facilities. This gives you a tally here of by county, the facilities, and then the number of beds. So that should give us this is 2019 data, so it gives us a reasonable notion of how many people, assuming the beds are filled, could be at risk for long-term care facilities getting coronavirus that way. We have an age distribution to see the older population. We also here have the uninsured, the persons uninsured. And this low over here is the adults uninsured. We see that we think this went down with Affordable Care Act, and we may see some places now where that's going back up. We also have some very recent annual poverty level rates by age. So there's, we think, a lot of useful things for folks to be able to look at there. Then we are also, second here, let's see, want to show, we now have been trying to do, as many other sites, showing things for COVID-19, all right? And our first effort here has been to just list sites, okay? We're trying to deal with the health things. We have, of course, the IDPH site that is updated daily. We have some economic impact sites, unemployment, etc. So we wanted to try here just listing sites for folks to explore and bringing together sites. We have the John Hopkins site, a variety of things. But we also have been preparing some of our own mapping and other information. This we have as of, this would have been yesterday's data. we've been calculating the rates, the confirmed cases per 100,000 population. And you see here we have 2 counties. This is not knowing now how this has been spreading in and being tested now in meatpacking facilities and communities. We have some areas here where the rate is very high because Louisa County and Tama County are very low population counties. And unfortunately, I have to say, these rates are rivaling or going above the rates we've seen in New York City and New York. So very high rates. And unfortunately, yes. So, and these have been counties now that have lots and lots of tests done. And some of the proportions where those tests are positive is very unsettling. So it's showing here some of the hot spots that we have. Let me back this up then. And I think we'll go back here. I just wanted to show those kinds of things. So you have a click point here to find various indicators and so on related to coronavirus. And I will stop sharing and I will come back to my PowerPoint. I am a person who's nervous about weather. Wait, you can't see it because I didn't share it. Okay, just a second. Hold on. Okay, we'll just go. Can you see the screen? Are you seeing? No.
Not yet.
Not yet.
Not
Okay.
yet, but we have a couple questions that have come in.
Okay.
So I want to let you finish, but just want to be aware of time.
Well,
We've got about
okay.
2 minutes left.
Yeah, I know we're getting, yeah. Let me share the screen. There, share. Okay. And I will put this onto, yeah, okay. So just to mention, the census deals with everybody across Iowa. It deals with our health, with our schools, with everybody. Kids, seniors, everybody in between. So get counted, all right? And here then is our contact information for me and our data team, the main people on our data team. Here's indicators.extension.aastate.edu. So now let me come back to questions, okay? So what do we have here?
Thanks so much, Sandra. That is so very interesting. Like I told you before when we were chatting, I've already completed my census form, and some of the questions struck me as being especially important this year with COVID.
Yes, it really is important to now have a really good basis of what we know about our people now. So.
Right. One of the questions that came in, it gets back to that, to race and ethnicity, and I remember this striking me when I took the census, it allowing you to say what is your national origin, essentially, or heritage anywhere.
Yes.
And are those categories being tracked as well?
Yes, those would be, if it's on there, they will tally those data at somewhere along the way.
Okay.
And it would not be in, well, I don't know. Given the questions of asking heritage for whites and for blacks and so on, you don't, for a long time you've been able to ask heritage for Asians, okay, and filling in Asian background, etc. So how they will table this and show it, I don't totally know, but there will be tables where you'd be able to see those origins that people show for being white and black and so on. So that'll be interesting to see.
It will be interesting.
Yeah.
So and then another question is does the U.S. Census affect the state legislature makeup? And if it does,
yes, yes, it does. That's the data that are supposed to come by the December 31st are the state counts that determine apportioning the U.S. House of Representatives. Okay. Then the counts that come, that are supposed to come by March 31st, which now are maybe get delayed. Those are the counts, because those are counts for all of our census blocks, our counties, our towns, and those determine how the districts are divided up within the state. So it's important for legislatures, and that's what that is given to the states for in terms of doing and redistricting legislative districts. For Iowa would be both House and Senate. Yeah. So it's
Go ahead.
It's political counting. Yeah, exactly.
Sure. Yep, good. And we all know how important our legislature makeup is and how decisions are made here in Iowa. So
Right.
I think this has been very interesting. I especially appreciate you sharing the link to the fact sheets, the county fact sheets that you are putting together.
Oh yes, those we hope they're really useful. You can just download every county, every town. We've got them all there. So
I will certainly be making use of those myself. So
yeah.
I'm sure everybody else will as well. So I just want to thank you again for your work, and thank you for the work that you do and for sharing it with us and adjusting to this platform here that we're using. And as we all get used to screen sharing and everything else. And thank you both, Tiffany and John, for being on as well and sharing your work, and all the attendees that are with us and sharing your thought-provoking questions. We all learn from each other, and asking questions is how we do that. So please join us every day at noon as we continue with our virtual conference. See, I'm having my own little screen sharing challenges here. So please join us every day for noon for what would have been the breakout sessions and poster sessions at our in-person conference earlier this month. The one thing that I've realized with this doing it Zoom is that we're able to attend more sessions this way. When we meet in person, we have to choose between concurrent sessions and poster sessions, and this way we get to take everything in. So I appreciate everybody joining us today. I appreciate all of our presenters staying with us and sharing your work. If you have missed any presentations, you will find them on our YouTube channel, the IPHA YouTube channel. And a reminder, if you're seeking CEU credits for this session, you need to complete the evaluation that is available on the IPHA website. And just as a reminder, we may be social distancing, but we are all still together. We're still a network, and we're all colleagues dedicated to public health in Iowa. So thank you again for joining us today.
Okay. Thank you for having us and taking the effort to do this.
Thank you, Lena,
so
and thank you everybody for attending.
Thank you. Yes, thank you very much.